So we said free radicals are agents that are formed from nitrogen and oxygen molecule, and they have a single electron in their outer orbit. They are highly reactive and they are very unstable. So that is why they are actively looking for molecules and structures to bind to so that they can achieve stability. And part of that molecule includes the lipids, include protein and DNA. So those free radicals they bind to lipid because peroxidation of the lipid, which can damage membrane because lipids are very abundant on cell membrane. They can combine with protein and cause cross-linking of protein. They can oxidize protein and cause damage to protein. They can also bind to DNA and cause DNA breakage. We talked about different sources for these free radicals, which include radiation exposure. So we said people that are exposed to radiation, the radiation can cause radiolysis, which is when water is split into um, the hydroxy radical and the hydrogen radical, which is H dot and O dot. So those radicals will attack the cell and cause protein modification, DNA breakage, as well as lipid peroxidation. So when all these things happen in the cell, that cell can be labeled for death by apoptosis. We said another method where we can generate the free radicals includes process of metabolism of drug, particularly the phase one that requires the activity of the uh, the cytochrome P450 system. So when the cytochrome P450 system is employed, it metabolize some drugs to free radical intermediate. So an example is when we're talking about acetaminophen, paracetamol, where it is converted to an intermediate that is containing so many free radicals, which is NAPQI, the N-acetyl-para-amino benzoquinoamine. Another example we gave was example of use of some industrial solvent like CCl4. So if somebody consumes CCl4, that CCl4 can be metabolized by the cytochrome P450 system in the liver, and it can be converted to a free radical intermediate, which is CCl3 dot, which is reactive. We explained redox reactions like oxidative phosphorylation generating free radicals, particularly superoxides, due to incomplete transfer of those electrons to water to oxygen rather to generate the superoxide radical. We said nitric oxide is one of those inflammatory mediators that's released from white blood cell, and they can readily go to form the reactive nitrogen species like nitrite radical, like peroxynitrite and the likes. We also said transition metals are very uh, key structures to forming free radicals in the body, particularly iron and copper, because they can easily go through the Fenton reaction, which involves combination with hydrogen peroxide to form Fe3 plus and OH dot. So uh, hydrogen peroxide can combine with iron in Fe2 plus state, oxidizing into Fe3 plus and generating the hydroxy free radical. So the same thing can also happen to copper, and it will also generate the hydroxy free radical. So those free radicals will be in the circulation and they can cause oxidative stress. The last one, comes from the white blood cell through the process of oxidative burst that we're already familiar with. So oxidative burst in which oxygen is taken up by the white blood cell, particularly the phagocytes, to generate free radicals in order to damage microbes. So the oxygen is converted to superoxide by the NADPH oxidase, then superoxide um, to hydrogen peroxide by superoxide dismutase, and the hydrogen peroxide can be combined with chloride to form hypochlorous, and all those intermediates can be used to damage the white blood cell. So those are ways by which the body generates all those free radicals. And we said there are some mechanisms that are set aside to help us take care of those free radicals. We said some of them can undergo spontaneous decay. There are scavenging enzymes that can mop them up, like catalase and glutathione peroxidase that can break them down. We said that some antioxidants are also neutralize them, like vitamin A, C, and E. Then we said for the metals like iron and copper, we have some carrier proteins like transferrin and ceruloplasmin that helps us transport them and keep them, you know, uh, out of circulation to prevent generation of these free radicals. We said there are some complications that can happen due to large exposure to free radicals. So one of them is from oxygen toxicity. So somebody is exposed to a lot of oxygen, person can generate oxygen free radicals, which can cause retinopathy of maturity due to abnormal vascularization of the eye. We explained the mechanism then. We said the oxygen reactive oxygen sheet can also combine with the epithelial cells of the respiratory tract in the baby, and it can cause damage and failure of development of the respiratory tract, causing bronchopulmonary dysplasia. Uh, Oxygen toxicity is also how injury can occur following reperfusion. So if somebody gets reperfused following an insult, the mitochondria from those dead cells will get exposed to oxygen again, and they will start producing free radicals, which can easily combine with those cells and cause further damage. We've talked about how free radicals can cause drug and chemical toxicity already by the exposure to acetaminophen and CCl4. But what I just want us to pay attention to is that for CCl4, the damage, particularly to the liver, is actually due to the fatty changes. So they cause necrosis of the they cause damage to the hepatocyte because of the lipid peroxidation. So that even can cause accumulation of the lipids there, and at the same time, the hepatocytes will die off. They can no longer synthesize the apolipoprotein, which is one of those ingredients I want to incorporate into our eventual lipoprotein. So if we cannot synthesize that and incorporate it into lipoprotein, there's no way our lipoprotein that are containing the fat can be secreted into the system. So they accumulate in the liver and cause fatty thing. And we said all these things, acetaminophen and CCl4, are metabolized by the cytochrome P450 system. And that cytochrome P450 enzyme, they are abundant within the centrolobular area of the liver. That is why they typically cause centrolobular necrosis and not periportal necrosis. We said the metal storage disease can also cause damage because when somebody has metal storage disease, there's overload of iron, there's overload of copper, like in hemochromatosis and Wilson disease, and generate a lot of radicals that can combine with the cells. We talked about ionizing radiation toxicity. We said ionizing radiation typically causes damage either directly or indirectly. So it causes it indirectly by generating free radicals, or they cause it directly by combining with all these molecules like you know DNA, proteins, and all those things. So they typically cause breakage of the DNA strand, particularly double strand break. So they cause a double strand break in DNA strand, and the body will have to utilize the DNA repair mechanism to either the homologous combination or the end-to-end journey to replace those damage, you know. And we said it causes some complication. For example, it can bring about localized inflammation because all those free radicals can damage the endothelial lining and cause inflammatory response with attraction of the white blood cell to that area, and it can also in a way activate the fibroblasts that will eventually bring about fibrosis. So the initial inflammatory response, just as shared with the typical cardinal symptoms of inflammation, which we are still going to talk about, including redness and edema. And eventually, after some days, the area will get fibrotic due to deposition of collagen to that area. So we said ionizing radiation, because of the fact that it can cause damage to DNA. At the end of the day, the cell is going to acquire a lot of mutation, and if the mutation affects an oncogene, it can drive the cell into a neoplastic change, which can, be the reason why ionizing radiation can cause so many malignancy, including leukemia, thyroid cancer, skin cancer, and the likes. And we said there's something that is called so basically two complications that I want to remember initially. The localized one, which is the inflammation and the fibrosis at the area of exposure. Then the generalized one, which is the systemic complication of causing malignancy. And there's also something we call the acute radiation syndrome, which is more like an acute reaction to exposure of to large dose of radiation at once. So, and we typically said the way we can remember this is just to picture that there's affectation of the rapidly rapidly dividing cells of the body, like the epithelial lining of the GIT, like the air, the skin, the hematopoietic structures, and all those things. So, if there is uh that initially there's this prodromal symptoms like headache and altered mental status, and there's damage to the epithelial lining of the skin. Epithelial lining of the GI. It can lead to nausea, vomiting, diarrhea. It can take care of the skin too and cause hair loss. There can be affectation of the bone marrow cells, which can cause both thrombocytopenia, even leukocytopenia, and anemia. So causing the cytopenia. So once we see that there is uh, nausea, vomiting, hair loss, erythema, following exposure to maybe a nuclear exposure, a nuclear plant explosion, or um, any radioactive accident. So we know that's likely to be acute radiation syndrome. So it typically damages the actively proliferating tissues because they are actively dividing and they are replicating their DNA. So those DNA can be exposed to the ionizing radiation, and the cell death can happen from that exposure. So we should know that the healthy cells that are actively dividing are damaged alongside with the cancerous cells, particularly if the cancerous cell doesn't have any DNA repair mechanism to take care of those repeated DNA that have been damaged from the ionizing radiation exposure. So those ones are more susceptible to dying from radiation exposure. Then we talked about calcification. We said calcification is just when we have deposit of calcium within the tissues, and calcium deposit within the tissue appears basophilic on H and E state. So this is a very important statement. Calcium deposit appears basophilic. We have two type of calcification: dystrophic or metastatic. Dystrophic or metastatic. So one is due to deposition of calcium in damaged tissue or diseased tissue. The other one is due to deposition of calcium in normal. So for the normal, that is the metastatic. Calcium is just depositing in normal tissue because it is too much in the body. So that means there's something that is pulling calcium into the system. There's something that is causing a calcium overdrive for the metastatic. While for the dystrophic, it typically occurs in normal calcium level state, but there's some destruction that is happening in the cell that is attracting those calcium to them. So we said dystrophic for disease tissues like all those necrotic structures from coagulative necrosis, as well we can see it in lymphact, liquefactive necrosis, uh, caseous necrosis in granulomas. You can even see in fat necrosis. Then we also talked about some congenital touches infection like CMV, toxo, rubella, like toxo and rubella causing intracranial calcification in the baby, while CMV causing periventricular calcification. We said it can also be present in some malignancy because malignancy are also disease state, so they can also attract calcium to them, and that calcium typically deposits in concentric laminated layers, which we call the psammoma bodies. Then, calcium can also deposit in blood vessels, typically blood vessels that are having atheromatous plaque or thrombi. They can attract calcium too. And calcium deposit is also part of the CREST syndrome. So the CREST syndrome is just a limited form of scleroderma. So the C for the calcinosis, which is the calcium deposit. C for there's a noise somewhere. Okay, I don't know. So all right. So C for the calcinosis, R for the Raynaud phenomenon, E for the ossified dysmotility, S for the sclerodactyly, and T for the telangiectasia. So the important part to us there is the calcinosis that is coming from calcium. Yes. So in dystrophic, the level of calcium is actually normal in the blood. It's just those diseased tissues that are attracting calcium. So when you see destructive calcification, you want to look at, okay, do we have any damage in this cell that can actually attract calcium? But for metastatic calcification, there is no disease foci. There's nothing that is damaged. It's just that the level of calcium in the body is too high, and those calcium needs to find a way to deposit in regions of the body. And we said that the deposition is widespread, so it goes to so many organs. But for dystrophic, it's localized. It typically goes to the organ that is diseased only. So we said metastatic, that is widespread, has predilection to deposit in tissues that are very alkaline, that is, tissues that are readily losing acid. And we mentioned three tissues like that: the interstitial tissues of the kidney that are readily excreting proton, H plus, in the urine. So that means they are alkaline because they are losing proton. We talked about the respiratory tissues because they are actively bringing out CO2. As we are taking in here, we are exchanging CO2 for oxygen. So that outward movement of CO2 makes the cells basic because CO2 is acidic. So as we are losing CO2, the cells are becoming basic so they can attract calcium. Then the last is for the gastric mucosa that are actively secreting acid onto the gastric mucosa, making the intracellular environment that is secreting those acids to be alkaline. So that is why there's predilection for the lungs, the kidneys, and the the stomach. So stomach, kidney, lung, stomach, kidney, lung. Those are the areas that are typically affected for metastatic calcification. So deposit of this calcium within the kidneys particularly can cause nephrocalcinosis. And the typical presentation of someone that has nephrocalcinosis is that because it typically affects the collecting duct and they present with nephrogenic DI. So they don't respond to ADH because ADH stimulates the collecting duct. So when there's enough calcium deposit at the collecting duct, those ADH receptors there, they don't work. So, and if it can't respond to ADH, there's no way they can reabsorb water because that's the function of ADH, is to stimulate reabsorption of water so that we can excrete less urine that is very concentrated. But if somebody is having nephrocalcinosis of the collecting duct, ADH cannot act on those those receptors again, and there's no way it can cause the kidney to reabsorb water. So that means we are going to be producing a lot of dilute urine, which is nephrogenic diabetes insipidus. Dilute urine because of failure of response to ADH. So at the end of the day, it can be widespread, it can go to other part of the kidneys and cause end-stage renal disease or renal failure at the end of the day. Okay, so what we said, metastatic is associated with an impairment in the calcium level. So what are those things that can raise the calcium level? If somebody has hyperparathyroidism, hyperparathyroidism can cause elevation of vitamin D, and vitamin D will increase the absorption of calcium from the intestine. It will cause the absorption of calcium from the bone, and the level of calcium will be high. Someone that has hypervitaminosis D from maybe consumption of vitamin D supplements, the vitamin D will also be reabsorbing the bone. It will resorb the bone rather. It will reabsorb calcium from the intestine and cause hypercalcemia, which will be depositing metastatic in the metastatic pattern. The last is sarcoidosis. We say sarcoidosis elevates the level of one enzyme, which is 1 alpha hydroxylase. 1 alpha hydroxylase is responsible is involved in the pathway to produce vitamin D. So when vitamin D is elevated, it can cause the hypercalcemia. And we said another cause for this metastatic calcification is also, aside for hypercalcemia, is also hyperphosphatemia. So, but we said that phosphate typically don't like to stay alone. So when there is elevation of phosphate level, it combines with calcium. So once it combines with calcium, they go about to deposit in tissues. So that is why hyperphosphatemia is also a cause for hypercalcemia depositing in tissues. So because it chelates those calcium and it will deposit those calcium in the tissues. And at the end of the day, the level of calcium in the serum will drop because all the calcium have been complex with phosphate to be deposited in the tissues. So we want to watch out for CKD, a chronic kidney disease causing failure of excretion of phosphate, so that phosphate will now pile up and now be forming complex with the calcium in the serum, and that complex will now be depositing in the tissue as metastatic calcification. So if they tell us in the question that they did the histology and they were seeing deeply basophilic calcium deposit in the tissue, they can ask us which mechanism it is. Is it dystrophic? Is it metastatic? So we have to figure out the mechanism. Is it that there's an ongoing disease that is happening, causing necrosis or injury that is attracting the calcium, or there's an elevation of the serum calcium level or serum phosphate level for any cause that is causing the calcium to deposit. So we talked about the Samoma bodies. We gave the acronym for that, which is the Samoma itself. These are bodies that contain calcified lumen or calcified lesion in laminated form. So there's concentric laminated calcified lesion or spherules that we typically see in malignant conditions because of the injury that is happening to those cells and deposition of calcium in them. So this is a form of dystrophic calcification. So what are those cancer that show Samoma bodies? The P is standing for papillary thyrocarcinoma. It stands for prolactinoma. It stands for papillary renal cell carcinoma. The S stands for the serous ovarian carcinoma, serous endometrial carcinoma. Somastatinoma is even there. The M is standing for meningioma. Is standing for mesothelioma. The O is like repetition of the ovarian carcinoma, and then we are done. Once we are able to remember that, we have remembered all the tumors that can show the Samoma body and histology. So, then we talked about amyloidosis. We said amyloidosis is a condition where we have aggregation and accumulation of amyloid protein. And we said we typically form amyloid protein um, when there is misfolding of those proteins. So when a protein accumulates too much, or there is uh, aging, and the mechanism that oversees the way those protein folds becomes reduced. So we have a lot of protein that are misfolded. Misfolded proteins tends to accumulate or aggregate together, and they assume a fibular form with a beta pleat sheet configuration. So we mentioned that. So we should just remember that the configuration of those proteins will change from the normal alpha helix to a beta pleated sheet configuration. So in that form, in that aggregated form, they are not degradable. You cannot degrade them. So if we cannot degrade those proteins by the activity of the proteins in the body, they will have to accumulate in the tissues and cause cell death and apoptosis. So we said one of the ways by which misfolded protein can cause cell death is by apoptosis through the intrinsic pathway predominantly. So once we're having a lot of accumulated protein that are misfolded, forming the amyloid fibrils which exist in the beta plated sheet configuration, they can easily accumulate because they cannot be degraded and cause cell injury. So what are the tissues that they typically go to? They can go to the renal, the kidneys, and cause nephrotic syndrome. So when they get to the kidneys, they typically cause damage um to the podocyte. They cause damage to the glomerular basement membrane, which are the filters for protein. So by the time they deposit within the podocyte and the glomerular basement membrane, they destroy these cells, and they allow protein to escape into the urine. So for us to say that someone has a nephrotic syndrome, we must be able to appreciate proteinuria of at least 3 plus. So that is that about the renal complication. 3 plus proteinuria on dipstick analysis of urine, nephrotic syndrome. Amyloid can also deposit in the heart. When it deposits in the heart, it causes restrictive cardiomyopathy. So cause a restriction in the relaxative ability of the heart. So the heart cannot relax and cannot pump well. So that is restrictive cardiomyopathy. It can also um, deposit within the electrical conducting system and impede them. So the person can be having arrhythmias. The person can have arrhythmia from there. It can go through the gastrointestinal tract and it will typically deposit in the liver and the spleen, making them big. So they will appear bigger than usual. It can deposit in the nervous system, and particularly it has predilection for affecting the peripheral nerves, so causing peripheral neuropathy. So they can be having tingling sensation, they can be having numbness, they can be having orthostatic hypotension, and all those symptoms of peripheral neuropathy. It can affect the muscles and the joint, musculoskeletal system. So if it deposits in the muscle, it can cause muscular enlargement. So particularly the muscle that is depositing is the tongue muscle. So we can see macroglossia, just like we said that day. Once we are seeing macroglossia, one of those things we are thinking is, do we have amyloid deposit in this tongue? And of course, you are going to be seeing the other systemic complication like the hepatosplenomegaly, the restrictive cardiomyopathy, and the nephrotic syndrome. So we can go back to the page and look at the last question I dropped. I think the answer was nephrotic syndrome. We can appreciate the way the person presented. So that's for the muscular deposition. They can deposit also in the joint and cause carpal tunnel syndrome. So they can deposit in the joint of the wrist and cause carpal tunnel syndrome, because when you deposit in that area, there's going to be compression on the median nerve of the deposition. The joint is going to appear swollen, and it compresses of the median nerve and cause typical symptom of carpal tunnel syndrome, like tingling sensation along the thumb, the second digit and third digit. There's weakness of all those digits too, because the median nerve has been compressed within the wrist from the amyloid deposit. They can also deposit in the other joint and cause arthralgia. But the typical way they like asking it is by um, painting the scenario of someone that has a carpal tunnel syndrome, particularly if the person has just if the person is diagnosed with CKD and the person is undergoing dialysis. So because the kind of amyloid protein those guys are going to generate is beta 2 um, um, globulin that has affinity for depositing in the joint as well as the nerves. So the last one that they usually like putting is this skin deposit, skin manifestation. It causes thickening of the skin, and the skin will appear waxy. So the skin will appear thick and waxy when there is deposit of amyloid in that area, and it can be easily bruised. Once we are seeing that waxy, thickened skin, it is amyloidosis until otherwise proven. It is amyloidosis until otherwise proven. Um, so how do we identify the amyloid deposit on electron microscopy or on polarized light? So we said the way we can identify amyloid is by staining it first with something, and that is a Congo red stain. So the next thing is now to visualize that Congo red stain in either non-polarized light or polarized light. So we said if we visualize it using a non-polarized light, we are just going to see the the typical redness, which is the red or the green, the red or the pink color, or the orange rather. So the red or the orange color. So from the name Congo red, the red color, that's what we are going to see from a tissue that is containing the amyloid when the tissue is observed with a non-polarized light following the Congo red staining. But if we apply the Congo red staining and we look at it using a polarized light, we are going to see apple green bifurcent. Apple green bifurcent. So if you don't want to use the Congo red stain, we can use the H&E stain. And because of the fact that amyloid deposits are deeply eosinophilic, they are going to appear pinkish using the H&E stain. So then we talked about the types of amyloidosis. We said it can be classified into the systemic form and the localized form. So we said the systemic form is just talking about um, causes of amyloidosis that can deposit in more than one organ. So it's not only one localized organ that is affected. So for example, we talked about the primary and the secondary, which are under the systemic because they deposit in more than one organ. So we are calling them primary and secondary because the type of protein that is aggregating in this amyloidosis is different. So someone that has a primary amyloidosis, what is aggregating is actually the light chain of the immunoglobulin. Where are these light chain of this immunoglobulin coming from? Because immunoglobulin are antibodies, so that means that they must be coming from plasma cells. So They typically arise from plasma cells dyscrasia, like multiple myeloma, malignancy that cause abnormal proliferation of plasma cells. So these plasma cells are abnormally proliferating and they are abnormally generating lots of antibodies, lots of immunoglobulin. And we remember in immunology that immunoglobulin has two components, the heavy chain, the light chain. Those are those things that undergo combination to form the constant region and the variable region. So in someone that has amyloidosis, we can have abnormal aggregation, abnormal folding of those heavy chain and light chain. Now, aggregation of heavy chain can also cause a form of amyloidosis, but we don't call that the primary one. It has another form of amyloid. It's not as common as aggregation of the light chain. So it's the light chain that typically aggregates and form, you know, the AL amyloid protein. So when we have abnormal misfolding of the light chain due to overproduction of the immunoglobulin, the light chain component aggregate, they become misfolded following the aggregation, and they form amyloid protein that deposit in almost all the organs of the body except the CNS. So primary amyloidosis, you can see almost all these this systemic manifestation from renal down to the skin. It has no, it can affect any one of them. That is the primary amyloidosis. Don't forget, it is the light chain that actually forming the primary amyloidosis. Those are the proteins that are aggregating the light chain of the immunoglobulin. I will call it the AL form. This light chain immunoglobulin can escape through the kidneys to spill into urine. And when it appears in urine, we call it the Benz-Jones protein. That is what we call the Benz-Jones protein from primary amyloidosis, which is secondary to multiple myeloma. The second form of amyloidosis is the secondary amyloidosis. It is also classified under the systemic because it affects more than one organ. The protein that's accumulating there is serum amyloid protein that is forming the AA protein. So AA, that's a short form, AA, or the serum amyloid protein A, which we said is an acute phase reactant that is typically produced in inflammatory reaction, in inflammatory response. So if inflammatory response changes from acute to chronic due to persistent stimuli, due to the fact that the injury, the insult that is causing that inflammatory response cannot be taken care by the body. So the body will have to switch to a stronger response, which is the chronic inflammatory response, to try to take it off. So we are going to have a lot of accumulation of those acute phase reactants like serum amyloid protein A, which can easily get misfolded and deposit as amyloid protein, particularly the AA form. So like I asked yesterday, whenever you are seeing aggregation of amyloid protein, and the type is AA, that is likely to be from a chronic inflammatory disease. You can name anyone. It's not specific. It can be from SLE, rheumatoid arthritis, IBD, familial, any chronic inflammatory disease can cause secondary amyloidosis due to deposition of serum amyloid protein A, which is an acute phase reactant that is elevated in inflammatory reactions. We talked about transthyretin. Transthyretin is also uh, an acute phase reactant, but it is one of those acute phase reactants that is downregulated in inflammation. So we are going to talk about it. So we can have two forms. So because of the fact that it is downregulated in inflammation, you can see that it cannot be a cause of secondary amyloidosis because when the inflammatory response becomes prolonged, it is downregulated, so there's no way it can accumulate. So, but how does it accumulate? It can accumulate in two situations: the sporadic type and the hereditary type. So the hereditary one is very straightforward. It is accumulating because of the fact that there's a mutation in the gene that codes for the transthyretin, which is also known as prealbumin or thyroxine binding prealbumin. So it's like a thyroxine binding protein or just prealbumin. You can call it anyone. So that is transthyretin for you. It accumulates in two conditions: hereditary form, sporadic form. So for the hereditary form, we are saying the reason why this protein is accumulating is that there is a mutation in the gene that codes for the production of this protein. So when that gene mutates, there's increased production of that TTR, that transthyretin. There's misfolding of the protein and it changes to form an amyloid protein that starts depositing in two major regions. It has predilection for depositing in two major regions: the nerves and the heart. The nerves and the heart. The nerves and the heart. So when deposit in nerves, just like we talked about, it can cause polyneuropathy. When deposit in the heart, it can cause cardiomyopathy. But we are going to change the terminology to a familiar form because it is caused by a mutation and the mutation can be inherited. So the familiar form. So that means if we are seeing within families, we are just seeing them having them they are having neuropathy, they are having cardiomyopathy, has been transmitted like that in the family. We are likely to be thinking of familial amyloid polyneuropathy or familial amyloid cardiomyopathy due to the position of transdirectin. So those are the ways we can approach those questions. There's no way we can be transmitting multiple myeloma through family. It's not inherited. We cannot be transmitting chronic inflammatory disease. No. So if you are saying that there's a familial acquisition of a particular problem like cardiomyopathy and polyneuropathy, where we should think of familiar form of this transdirectin mutation. For the sporadic one, it is actually due to the fact that this person is aging and the mechanism, just like I said, that helps to regulate the normal protein folding becomes compromised. They are gone because the cell has aged. So they cannot actually correct all those misfolded protein. So they will aggregate, and part of them is transthyretin. So transthyretin can aggregate in that form, and it will cause a sporadic form of transthyretin amyloidosis. But this one typically likes depositing within the ventricles and cause cardiomyopathy only. So, but in some situation, it can also deposit in the nerves because that's why it's classified under systemic. It has to deposit in more than one tissues. But it has predilection for depositing to the heart. And it can cause arrhythmia, it can cause cardiomyopathy. We should not forget that. Sporadic and hereditary. Sporadic and hereditary form of transthyretin amyloidosis. The last one for the systemic is the dialysis associated or dialysis related amyloidosis. And the amyloid protein that is accumulating in that one is the beta 2 microglobulin. We said it's very commonly seen in individuals that has an end-stage renal disease or a CKD and they are placed on hemodialysis. So when these people are placed on hemodialysis, because what hemodialysis is actually doing is just to help them remove the waste product in the blood and filter them out and they can be excreted. Beta 2 microglobulin is present in almost all the cells of the body and normally it should be excreted by the kidney. So it means if somebody has a CKD, they cannot excrete beta 2 microglobulin and it accumulates in the body. Now that aggregation, that precipitation of this beta 2 microglobulin is further exacerbated in someone that is now undergoing dialysis because dialysis filter cannot excrete this beta 2 microglobulin. They cannot filter it out. So it will now accumulate in chunks within the blood and they can easily misfold and cause amyloidosis. So this one typically deposits in the ANS, causing neuropathy, and it typically also deposits in the joint, causing the carpal tunnel syndrome, just like we talked about. So it's not that it is only people that are having dialysis that can have it. Even at the end of the day, someone that is having ordinary CKD without dialysis will eventually develop this amyloidosis from this beta 2 microglobulin, but to just be of earlier onset in someone that is undergoing dialysis. So we are done with the systemic form, but now looking at localized form of amyloidosis that typically occurs in some specific organs only. So the first one is Alzheimer's disease. So Alzheimer's disease um, is a condition in which there is accumulation of one protein that we call the amyloid precursor protein. So that amyloid precursor protein accumulates and it can be broken down to beta amyloid protein. That beta amyloid protein accumulates and becomes misfolded and it can transform into amyloid protein that deposits in the brain. So they typically deposit in some regions of the brain like the hippocampus and cause the typical symptoms of Alzheimer's disease like memory loss. So we should not forget that the amyloid protein that is depositing in someone that has Alzheimer's disease is the beta amyloid protein, which is derived from the amyloid precursor protein APP. So APP breaks down into BP, the beta amyloid protein that deposits in the brain. You only find that beta amyloid protein deposit only in the brain. So someone can have what we call isolated atrial amyloidosis. So this amyloidosis is actually caused by over deposition of AMP within the atrium of the heart. AMP typically is produced from the atrial muscles as well as the atrial muscle, although some can have some amount of the ventricular muscles too. But, you know, the atrial muscles typically generate the no, it's even from the atrial muscle. Sorry, I'm talking about another thing. That's BMP. So atrial muscles typically generate the AMP, that's the atrial natriuretic peptide, particularly in response to the stretch of the muscles. As an individual age, they cannot control the folding of that AMP protein. So they become misfolded and they can accumulate in the heart and cause amyloidosis. So that person will be having isolated atrial amyloidosis, which is deposition of the AMP in the heart, and it can cause atrial fibrillation. So they can be disturbances of the electrical conductive system and can cause atrial fibrillation. It can even cause heart failure, in which the heart is not able to pump very well due to that deposit. So it's very associated with aging. It's just like the sporadic form of transthyretin amyloidosis. Both of them are associated with aging. The next one is type 2 DM. So somebody with type 2 DM, one of the pathophysiology is actually due to islet amyloid polypeptide that is deposited. Islet amyloid polypeptide is also known as amylase. So if we take a look at the way type 2 DM happens, we are going to notice that there's an initial insulin resistance, either from the fact that the person is based, you know, and the insulin receptors are not, they are resistant to insulin. So because of that insulin resistance, the beta cells of the pancreas will be forced to overproduce insulin. They will be like, is it that the insulin level is not enough to stimulate the receptor? Is that why we're having hyperglycemia? Is that why we cannot have a drop in the glucose? Let us overproduce that insulin. So when they keep producing that insulin, production of insulin from the beta islet is coupled with the production of amylin. So as the cells are releasing insulin, it is always associated with the release of amylin. And amylin is known as islet amyloid polypeptide. Now, it will get to a time that the amylin is going to accumulate, because of the resistance. So when the insulin accumulates, the uh the amylin protein also accumulate, they will start getting misfolded. So when there is a misfolding, they can now accumulate in the source, which is the beta islet of the pancreas, and they can further damage those pancreatic islet cells. So that is why when we are doing endocrine, we said, fine, um, type 2 DM is due to insulin resistance. It's not due to problem with the beta pancreatic islet cells. But with time, we are going to be having destruction of those beta islet cells. It is due to this amyloidosis. It is due to this amylin depositing in the beta islet cells. So we should not forget that. Type 2 DM, not type 1, not type 1. So the last one is medullary thyroid cancer. So someone that has medullary thyroid cancer, there's overproduction of calcitonin. So with time, some of those calcitonin protein will get misfolded and they will form amyloid fibrils that will start depositing in the thyroid gland themselves. So biopsy those thyroid glands, we stain them. We are going to see the apple green birefringent following observation with polarized light after Congo red staining. It's due to the fact that the calcitonin has formed amyloid fibrils that is depositing in the thyroid gland. So what is actually causing predilection for, or what is selectively causing all this particular protein to be forming all this amyloid is actually due to the primary structure of the protein, that is the amino acid sequence that they contain. So there are some amyloidogenic amino acid sequence that if some protein contain those sequence, they will typically form amyloid deposit. It is also dependent on um the stability of the protein. So not all proteins are stable. So there are some proteins that are not very stable. So they can easily become unstable and get misfolded and cause amyloid deposit. So that is that about amyloidosis. So we are going to start inflammation now. So
Dr. Babawale, good morning. Please, what was the first point that you said causes amyloid proteins?
so I said there are some the primary structure of the amino of the protein. So when we say primary structure of a protein, we are talking about the sequence of amino acid that protein contains. How is it sequenced? Is it glycine, leucine, aspartate, glutamine, the arrangement. That's the primary structure. So there are some sequences that are amyloidogenic, that is, they favor formation of amyloid. Do you get it, Dr. Paulette? So
Yes.
if they have that particular sequence, they will easily, go and form. So there's a possibility that all these proteins that we are looking at are very unstable, and they have those sequences. That is why amyloid typically affect them. We can ask ourselves that question: why does insulin not form amyloid? Why does growth hormone not form amyloid? Why does all those other proteins? So it's because of the fact that all of them have different level of stability. So that is that. So let's go to inflammation. So we are just going to make everything very snappy. Uh, we don't have much here. So inflammation is just a response of vascularized tissue. It's just like vascularized tissue are responding to an insult. They are responding to an offending agent by by recruiting white blood cells and mediators of host response to eliminate that offending agent. So we want to eliminate the offending agent. We want to remove the necrotic tissue or the dead tissue that the offending agent have caused. Then if there's any damage that is there, we want to repair it. That is inflammation. So response of vascularized tissue to an insult by bringing in leukocytes, by bringing in other molecule of inflammatory response like the complement proteins, in order to remove the injurious stimuli, to remove the dead tissue that the injurious stimuli has caused, and to initiate tissue repair. That is inflammation. It must involve the vessels. It occurs within the vessels due to vascular changes and cellular changes. So the vessels will change, the cells within the vessels too will move to that area to respond to the injury. So what are the types of inflammation? Acute and chronic. Acute and chronic. So the way to just understand this is just to to um to pay attention to the fact that in acute inflammation, it's more like a rapid response that is short acting, that is short lived. The response is just very fast. Acute inflammation is actually the best one. It is the one that, or it's better rather, because we are looking at two things. It's better, and it's the one that is beneficial to the body. Chronic inflammation is not beneficial to the body. It even causes injury to the body. So the typical way the body should respond an to an injurious stimuli is just what? To undergo acute inflammatory response. It's just to respond to it briefly and quickly. We recruit the white blood cells to that area. The mediators of inflammation are released so that they can take care of those injurious stimuli and initiate repair if it's necessary. And you have complete resolution. That is it. But it can get to some extent that the body host response might not be able to take care of the injurious stimuli. It is persistent. So they want to employ bigger machinery, which contains some chronic inflammatory cells that will actually cause damage to the body. So, number one, to differentiate between acute and chronic inflammation, we look at the cell type. In acute inflammation, it is more of the neutrophils and the macrophages. The neutrophils and the macrophages, and it is very short-lived. Within like 3 to 5 days, they are done. They are done. But in chronic inflammation, it is employing the services of the mononuclear cells, cells that have only one nucleus, like the macrophages, like the lymphocytes, and the plasma cells. And those ones are there to cause a very severe damage to the structures. We are going to talk more about them. So, we are saying inflammatory response is beneficial so that if somebody has an infection, we have response of the white blood cells to it, particularly neutrophils. If it's a bacterial infection, they respond to it, they phagocytose those bacteria, and they destroy them. And there's subsidence or resolution of that inflammatory response, and there's no damage. Everything goes back to normal. But if the infection is a persistent one that is very stubborn, and the neutrophils or the macrophage cannot even take care of it, and they start employing the service of the T cell, the fibroblasts, the macrophages, and other things, those ones can collectively cause damage to the cell particularly by forming granulomas or fibrosis, which is bad. So that is why we are saying inflammatory response, when it's acute, can be beneficial, but when it's chronic, it is bad. So even aside the fact that it's chronic, if that acute inflammatory response is prolonged, it is excessive, it can be bad in the setting of septic shock. So if somebody is having a localized infection of the skin before and there's an inflammatory response to it, and maybe in a way those inflammatory cells are able to find their way into the blood. Once it gets into the blood, it will tilt the inflammatory response to an overdrive. So you have a lot of neutrophils, a lot of macrophages, a lot of dendritic cells, a lot of mast cells in the blood responding to that bacteria. So in the process, they are going to release some interleukins like interleukin 1, interleukin 6, TNF alpha. And we can remember in our immunology, that is why all these things, they go hand in hand. They go hand in hand. So we said it then in our immunology that TNF1 and TNF alpha and interleukin 1 can cause vascular permeability. They can cause fever. They can act as chemokines that can attract more white blood cell, and they can also cause increased vascular permeability. So when it damage the vascular, when they cause a contraction of the vascular endothelial cells and there's increased vascular permeability, you can have plasma content extravasating from that intravascular space into the tissues, and that is the cause of the edema. So when that becomes too much and you have a lot of fluid moving out into the extracellular compartment, you have little fluid in the intravascular space to perfuse all our distal organ. That is the mechanism of septic shock. So shock happens because there's underperfusion of the organ due to the fact that there's an excessive, there's an overdrive of release of these cytokines that damage the endothelial cells, causing extravasation of fluid into the extravascular space, and there's little to go to our organs, causing shock. Of course, it's going to be septic because there's already a bacterial focus in the blood. We are going to see the cardinal signs of SRS, which include some changes like hyper fever. There is going to be increased respiratory rate. There's going to be increased heart rate and all those things. Then we can also demonstrate what's it called, bacterial focus, maybe from culture or from anything. And there's going to be leukocytosis too. So once you are seeing all that, you know that okay, this is likely to be sepsis, and we can say it is now causing shock because it has caused endothelial injury and there's extravasation of fluid outside the vessels. Then there's little perfusion to the organs, causing the shock. So it is due to inflammation that is excessive. If the bacterial has not gotten into the blood and they have not caused elaborate release of those interleukins, we will not have septic shock happening. So that is one way inflammatory response can be harmful. Another way it can be harmful is when it is responding to an infection that is persistent, that is very difficult to eradicate, like tuberculosis. So what the body will try to do is to contain that tuberculosis. They will now employ the services of the macrophages, the T cells. They are going to encase the organism in granulomas. So when they form granulomas, because in granulomas there's going to be area of necrosis. You can be having calcium deposit there. You can be having calcification of tissues. You can even have the macrophage that is activated, releasing growth factors that can activate fibroblasts, which will now cause fibrosis of tissues. So when a tissue becomes fibrosed, they become less active compared to normal tissue. So they can't function properly because of the fibrosis. So that is the way um, granuloma formation, fibrosis can cause, due to inflammation, can cause cell injury or problems for the body. In some situations, inflammatory response may be inappropriate. They are directed towards stimuli that is not supposed to be. When we're having inflammatory response to our self-antigen, that is an inappropriate inflammatory response. So that typically occurs in autoimmune disease. So just imagine we're having inflammatory attack to our heart in someone that has acute rheumatic disease, and they are forming antibodies against the M protein of the heart muscle. They are causing damage to the heart muscle. That's an inflammatory response because the antibodies are being generated and all those things. If we don't want to look at that, we can look at type 4 hypersensitivity reaction. So due to recruitment of the T cells, through self antigens, that can cause problem too for the body. So inflammation can be problematic in some situations, like in septic shock due to an excessive inflammatory response, or when it is prolonged with formation of granulomas and fibrosis, it can cause damage, or when it is inappropriate, in which is not getting directed towards the right stimulus it should be directed to, particularly in autoimmune diseases. It's a problem too. So what are the cardinal signs of inflammation that I want to look out for? These are the signs of inflammation that are localized to the area that is being inflamed, to the area that is having that injurious stimuli. So I know we are familiar with this. So they include the rubor, the calor, the tumor, and the dolor, alongside with functional assays. So rubor and calor means the same thing. Redness is rubor, calor is warmth. So calor is like heat, redness and warmth. So what is the cause of rubor and calor? So let's say there's somebody that gets infected with a bacteria in the skin, and there's vasodilation. So that the next thing is the mast cells that are there, the dendritic cells that are resident of that area of inoculation, you know, will release some substances, some preformed substances, usually like histamine. So what they are trying to do is just to achieve vasodilation, so that white blood cells can arrive at that location and take care of that offending agent that has entered the body. So vasodilation is actually mediated by relaxation of the arteriolar smooth muscle. So we have different components of the vasculature. We have the arterioles, we have the capillaries, and we have the venous. So after the artery, we have the arterioles, then we have the capillaries, then we have the venous. So in between the capillaries, we have the arterioles and the venous. They are more narrow compared to the veins and the arteries. So the part of the body that actually determines the peripheral vascular resistance is the arterioles. If they put it in option, they put all the part of the vasculature that which determines, you know, the resistance, which undergoes dilation or vasoconstriction predominantly. It is actually the arterioles, the arterioles. So those are the parts that the histamine will work on. So the histamine is going to be released from the mast cell, from the dendritic cells that are occupying that area, and they are going to cause vasodilation so that we can have more blood flow to recruit the white blood cell. So blood flow will bring um will cause, because blood is red, so it will make that area look reddish, which is a rubor. And because of the fact that there is metabolism that is happening in the body, and one of the waste product of metabolism is heat. So it means that if there is increased blood flow to an area, they can deliver heat to that area and it will appear warm. So vasodilation is both responsible for the redness and the warmth that is associated with vasodilation, that is associated with inflammatory response. Now, what are these mediators that are very, very important, will respond to this vasodilation? I want us to always remember our histamine and bradykinin first. Histamine and bradykinin are involved in almost all the cardinal signs. We must remember that first. Histamine and bradykinin. Histamine and bradykinin. Once you mention them, you cannot be wrong. You can never be wrong. Histamine is just preformed. Bradykinin needs to be synthesized. So, in addition to bradykinin, prostaglandin I2. So we call them prostacyclin. Prostaglandin I2, for people that have done cardio, they will remember prostaglandin I2, they are vasodilatory. So in addition to prostaglandin, there's another mediator that is vasodilatory, and that is nitric oxide. Nitric oxide. Nitric oxide. So nitric oxide, histamine and bradykinin that we have mentioned, histamine, bradykinin, nitric oxide, and PGI2, they are vasodilatory. They will increase blood flow to that area due to relaxation of the arteriolar smooth muscle, which will lead to delivery of more white blood cell. The area is going to appear red, and there's going to be warmth in that area. What next after we have had vasodilation? The next thing is that the interleukins, the TNF that have been released by the cells that have come around, the cells, the white blood cells that have come around will start releasing some of those interleukins in response to those microbes that is causing the inflammation. So those interleukins are going to act on the endothelium because they must be able to find their way into the tissues. The microbes are in the tissues, not in the vessels particularly. So we need to leave the vessels to get to the microbes in the tissues. So how will they get there? They have to leave they have to move across the endothelium. So now that is when we now have disruption or contraction of the endothelium. So those interleukins are going to cause contraction of the endothelium. So when the endothelium contracts, they kind of increase the gap in between the endothelial cells. So when they contract, when they make the statement of endothelial contraction, they're actually saying that there's an increase in the gap between those endothelial cells, which can allow leakage of protein-rich fluid from the post-capillary venous. Now, these changes is now happening in the post-capillary venous, that is the venous, which I said is just after the capillary, not the arterioles now. Vasodilation happens in the arteries. The endothelial contraction affects the endothelial cells of the venous. So once they contract, we can have protein that is very rich, the plasma that is very rich in protein to leave the blood vessel into the tissue. So when fluid leaks into the tissue, it's going to cause swelling of that tissue, causing tumor. At the same time, white blood cells are going to follow it too. White blood cells are going to follow it to get into that tissue to eliminate the offending agent. Now, because of the fact that that fluid that is there is rich in protein, we call it an exudate. So that is why when we start talking about exudative pleural effusion, transudative pleural effusion, we're able to differentiate them by analyzing the protein content, the cellular content. So a fluid or an effusion or a fluid that is rich in white blood cell, that is rich in protein, is called an exudative fluid, an exudative effusion. So that means that exudative effusion follows inflammation because it is only in inflammation that we are going to have release of interleukins that cause damage to the endothelial cells that allows escape of proteins and white blood cell into the tissues. So it means that someone that has heart failure, their own edema is not exudative because there's no inflammation and there's no damage to the endothelial cell. Their own is transudative. That fluid that is extravasating from the intravascular compartment into the extravascular compartment is not containing any protein. It's not even containing white blood cell. So what is driving in heart failure is just pressure difference. So the pressure difference will just make the fluid move across the endothelium into the tissues. That's in heart failure. But for us to have protein moving into the tissues from the lumen of the blood, from the vessels, you actually have to have a compromise of the endothelial cell. That is why any inflammatory disease will cause exudative effusion. So if someone has a malignancy, if somebody has an infection like pneumonia and all those things, the acute pancreatitis, they are going to have exudative effusion in them because of all these things that we have talked about. So because of the fact that protein is also moving into the tissues, the interstitial oncotic pressure is going to high. It's going to increase. It's going to increase. It's going to increase. So what are those things that actually cause endothelial contraction, which is which allows for fluid to move in so that we can have swelling at the end of the day of that area? We must remember leukotriene first. That leukotriene is the most important. The leukotriene, particularly the C4, D4, and the E4. We also call these guys the slow releasing substance of anaphylaxis. C4, D4, and E4. Those are the leukotrienes that are involved in causing contraction of the endothelial cells so that fluid can extravasate containing the plasma protein, which includes the complement protein, as well as white blood cells to damage, those injurious agents within the tissues. So because of the fact that fluid is leaking, it's going to cause swelling. So that's why swelling is one of the cardinal symptoms of inflammation. So in addition to that, I've told us that histamine and bradykinin is central. So bradykinin is not here, but we can't list all of them. So histamine and bradykinin actually causes this endothelial cell contraction too. Then the last one you want to remember is serotonin. So serotonin, the way you can remember serotonin is just to picture it as an inflammatory mediator that can only cause vasoconstriction and endothelial contraction. So serotonin is not part of what causes vasodilation. It actually causes vasoconstriction. But in addition to vasoconstriction, it causes endothelial contraction too. And that's the only thing it does. That's all. Serotonin is done with the function.
So the last one is pain. Pain also accompanies inflammatory response, and this is the fact that we have stimulation of the sensory nerve endings. So what are these things that stimulate them? We remember our histamine, our bradykinin again. You can see that it's very easy. We remember our bradykinin and histamine again. Those are the things that stimulate the sensory nerve endings in those tissues and bring about the pain. So in addition to that, PGE2 also stimulates the sensory nerve ending and cause the pain. That is why if we want to relieve pain following an inflammatory response, we can give aspirin, we can give NSAIDs, which are going to inhibit the formation or the synthesis of PGE2. So it makes sense to give aspirin uh, to reduce pain because it will inhibit the formation of PGE2 and cause relief of the pain. So pain, PGE2, then our bradykinin and histamine. Then at the end of the day, all these things is going to culminate in loss of action. Just imagine that what is causing the initial inflammatory response is when this person has bacterial infection that has penetrated the dermis to and that has got into the subcutaneous tissue, and you have an inflammatory response to that. That inflammatory response is going to cause the redness, is going to cause the warmth due to vasodilation, is going to cause swelling due to extravasation of fluid that is rich in white blood cell and protein into the tissue itself, causing swelling. So, and those are the cardinal things that we see in someone that has cellulitis. So, if there's affectation of the subcutaneous tissue, like we have in cellulitis, we have all these cardinal signs. And at the end of the day, because of the pain, because of the swelling, you'll not be able to use that region. So, that is the last component of the cardinal sign, loss of function or functional lassay. Everything, this functional lassay is actually a consequence of all these things that we have um, mentioned earlier. So the swelling, the pain will not be able to make us use that particular organ that is undergoing inflammation, and there will be impaired activity or impaired use of that organ. That's the fasciolaceae. Fasciolaceae. So you must remember the rubor, the calor, which is due to vasodilation that typically affects the arterioles in response to histamine, bradykinin, prostaglandin, and nitric oxide. Then the next one is swelling, which is a suppression of fluid causing tissue swelling, and that fluid is rich in protein and white blood cell. And what is causing the contraction of the endothelium that is causing increase in the gap of the endothelium that is making way for those guys to pass through is leukotriene, like we've said. Leukotriene is the number one. Then you remember your serotonin and your bradykinin and histamine. Then the last one is the pain. Bradykinin, histamine due to stimulation of the sensory nerve ending and PGE2. So, in addition to these cardinal signs that we are seeing in the localized tissue, what are those ones that are happening within the system? What are those ones that are happening in the other part of the body? That is what we call the acute phase reaction. Three things that we need to remember: fever, leukocytosis, and elevation of the plasma acute phase reactant. So we must always, that's why in most setting of inflammation, we're always saying fever. Fever is one of the cardinal symptoms. Fever. Why? Let's say that there's a bacterial infection. It gets into the uh, tissue, and it's because of the fact that there's something we call pyrogen. So pyrogens are just like markers within the microbes that can stimulate fever. That's why we call them pyrogen. Pyrogen kind of it's maybe it's a term for fever. Something that is pyrogenic can induce fever, depending on the microbe. If it's um, um, a bacterial infection, they will have the lipopolysaccharide, particularly a what's it called? A gram-negative bacteria. So they have this lipopolysaccharide as their pyrogen. If it's a gram-positive, they can express lipotechnic acid. If it's virus, it's the DNA that is pyrogenic. All these things are collectively known as the pathogen associated molecular pattern. So I know that we have talked about that in immunology. Pathogen associated molecular pattern. That is, what are the molecular pattern that is associated with the pathogen that can be recognized by the white blood cell? All these things: lipopolysaccharide, lipoteichoic acid, the nucleic acid of viruses. So once they get into the system, there's something we can remember from our innate immunity that we call the toll-like receptors. The toll-like receptors. So those toll-like receptors are like receptors for the PAMPs, the pathogen associated molecular pattern. The toll-like receptors are typically present within the macrophages, the dendritic cells. So they can respond to all those microbes. So once they recognize the LPLs, the lipoteichoic acid, there's going to be a reaction to it, and macrophages will release interleukin 1 and TNF alpha. We remember that interleukin 1 and TNF alpha are the major interleukins that induce fever from our immunology. How did they do that? They are going to cause increased activity of COX, cyclooxygenase. They are going to increase the activity of cyclooxygenase in the perivascular cells of the anterior hypothalamus. So hypothalamus is it's just like a regulatory center of the body that helps to control temperature. So they want to alter the activity of that hypothalamus and make it, increase the body temperature. How are they going to do it? Once the microbes comes in, they are recognized by the macrophages. The macrophages elaborate interleukin 1 and TNF. The TNF and interleukin 1 will travel in blood to the perivascular cells of the anterior hypothalamus, which is like the thermoregulatory center. What will they now do? They are going to increase the activity of cyclooxygenase in those cells. What will cyclooxygenase activity do? It will increase the level of PGE2, because cyclooxygenase is one of the enzymes that can increase production of this PGE2, particularly COX2, because this is PGE2. If it's PGE1, that will be COX1. So PGE2 is COX2. And one thing I want to say about cyclooxygenase 2 or COX2 is that COX2 is elevated in inflammation. COX2 helps to drive inflammatory response because it produces some prostaglandin like the PGE2, PGF2 alpha, PGI2 that are very important in inflammation. The COX1 prostaglandin like PGE1, F1 and all those ones are not very important in inflammation. Those ones are important in maintaining normal tissue integrity. They are the ones that are maintaining normal mucosal integrity in the GI. They are the one that is ensuring adequate blood flow to the kidneys and all those things. Those are what they do. They are constitutive. They are released every time so that they can maintain homeostasis. But the COX2 produces PGE2 and the other E2s, like I2, that can drive inflammation. So we remember that I said that the 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 prostaglandin that is involved in causing vasodilation is what? PGI2. So it's coming from the increased activity of cyclooxygenase 2, which is a cyclooxygenase that is active in inflammation. So in addition to production of PGI2 that's causing vasodilation, which is one of the cardinal signs, it can also increase production of PGE2 in the anterior hypothalamus. And what will this PGE2 do when it gets to the anterior hypothalamus? It's going to increase the set point. What that means is that it's going to increase the 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 set point of the temperature in the hypothalamus, and it will make the body believe that are we cold? Let us work to achieve this set point. So that's how the body is designed. The body will always want to work to catch up with the set point of the hypothalamus. If the set point of the hypothalamus is high, it's like a bar. You want to meet up with the standard, you want to meet up with the bar. So if the set point is increased, the body wants to do whatever it can to increase the temperature to that set point. If we, in whatever way, reduce the set point, the body will want to work in some other way to reduce the temperature in order to respond to that decrease in the set point. Now, how will the body now adjust in response to this increased set point? Because we have increased the temperature set point, that means that we have to work more to also increase our body temperature to that set point. So the body will now increase the rate of metabolism. There's an increase in the rate of metabolism so that they can generate more heat and make the core temperature increase towards the set point. And also, there's this shivering mechanism. So the body will start contracting its muscles, causing shivering, and muscular contraction can generate heat. So that is why people that are feverish, they're actually shivering because they are trying to generate heat to meet up with the temperature set point that is increased. That is it. That is the pathophysiology of fever in inflammation. Don't forget the activity of interleukin 1 and TNF alpha, as well as the COX activity. That is why if you give somebody aspirin that can block both COX1 and COX2, you are going to have reduction in the fever. That's the antipyretic action of aspirin. It inhibits cyclooxygenase activity. The same thing with acetaminophen, paracetamol, bringing down fever. They inhibit cyclooxygenase activity. And this cyclooxygenase activity is increased in response to interleukin 1 and TNF alpha within the perivascular cells of the anterior hypothalamus. So that's one systemic response. What is the next one? Leukocytosis. Look at the term. Leukocytosis. Increase in the white blood cell count. The normal white blood cell count ranges between like 25 to like 11,000. So if it goes beyond that value, you know that that is likely to be an inflammatory response happening somewhere. The type of the specific cell of the white blood cell count that is now elevated will now tell us the kind of agent that is driving that inflammation. If it's a bacterial agent, we are going to have predominance of neutrophils. So neutrophils are going to be the one that will be very abundant. Neutrophils in bacterial infection. If it's viral, lymphocytes, lymphocytes, lymphocyte for viral, bacterial for neutrophil. So the old guys, which bacterial infection doesn't cause increase in the neutrophils, but what they have is lymphocytosis. Which bacterial infection is that?
Pertussis.
So pertussis. It is only in pertussis that the inflammatory response is actually due to elevation of the lymphocytes. Don't forget that. Don't forget that. Don't forget that. There's a reason why I'm saying that. Do not forget that, because it can come on the D-Day. Pertussis is the only one that causes lymphocytosis, not increase in the neutrophil count. But other bacteria will increase neutrophil. If it's going to be viral, we are going to have lymphocytosis. Yeah. So all those things will cause increase in white blood cell count in total. Then the last one is elevation of the plasma acute phase reactant. So there are some proteins that we call the acute phase reactants that what they just do is just to help us regulate and modulate the inflammatory response. They can help with the inflammatory response because some of them can act as opsonin. So I want to use this medium to tell us that it is not only C3b, it is not only IgG that is an opsonin. We have some acute phase reactants that are opsonizing too, and they can facilitate the recognition of those microbial agents by the phagocytes so that they can take care of them. That is opsonization. When we have an agent that can readily make the phagocyte recognize the offending agent and take it out, that is opsonization. Some acute phase reactant does that. Some acute phase reactant also what helps us suppress the activity of the microbes, the tendency of the microbes to grow and proliferate and cause the inflammatory response. They suppress it. We are going to talk about it. Some of them helps to initiate the process of tissue repair. We are going to. So they have different roles that they play. But what factor is responsible for the elaboration of this acute phase reactant? We must always remember it. Interleukin 6 is in immunology. I know we did it in immunology. And that is one of those things that they listed for interleukin 6. Elevation of acute phase reactant. That's what it does. Elevate acute phase reactant. Interleukin 6. So you see it in both acute and chronic inflammation. It's just that when the inflammation is now moving from acute to chronic, you're having a lot of accumulation of those acute phase reactants, particularly the ones that are upregulated, because it is not all acute phase reactant that is elevated in inflammatory. Some are elevated, positive acute phase reactant are upregulated, some are downregulated. So we'll look at which now. Now, this is the basis why serum amyloid A can cause amyloidosis, because it's one of the acute phase reactants that is upregulated. So once it gets to chronic inflammation and it has accumulated, it will now start misfolding and start causing amyloidosis. So let's look at the acute phase reactants. Let's look at them one by one. So we have the ones that are upregulated, just like you can see. We have those ones that are downregulated. So the ones that are upregulated include C-reactive protein. So C-reactive protein are upregulated. Thank God that it is just 3 that is downregulated. So it's very easy for us to remember. So the other one, just assume that the other ones are upregulated. C-reactive protein is upregulated. It has different role. What does it do? It has opsonizing activity. So C-reactive protein can bind to the pathogen-associated molecular pattern within the microbes. It can bind to both the damage-associated molecular pattern and the pathogen-associated molecular pattern. So because inflammation is in response to both infection and damaged tissue. Remember, we said that necrosis triggers inflammation. So it means that all the damage-associated molecular pattern that is elaborated from those damaged tissues, all the pathogen-associated molecular pattern that is elaborated by those microbes can be recognized by opsonin. So opsonin will be able to attach to those offending agents, and it will label them for increased recognition by the phagocyte. So the phagocyte will rush to them and to phagocytose them and cleave them off. That is opsonization. C-reactive protein has also been shown to activate the classical pathway of inflammation of complement system. C-reactive protein activate the classical pathway of the complement system, increasing the activity of C1q, which increase the production of C2, C4, which will get to C3. I know we remember that. And C3, and in that way, it can help us fix complement. So don't forget, C-reactive protein can fix complement because of the fact that it can activate complement through the classical pathway. Then it can also opsonize. Both of them working together to facilitate phagocytosis, because by the time you are producing your C3b is an opsonin, so it can stimulate the phagocyte to take care of the offending agent. I want to mention that C-reactive protein is not a specific marker for inflammation. That is, it is not what we mean by this statement is that you cannot say that this inflammation is due to infection. We cannot say that this inflammation is due to autoimmune disease. We cannot say that this inflammation is due to foreign body. We cannot say that this inflammation is due to um, necrotic tissue triggering inflammation. We cannot say, but we shall know that inflammation is happening. So it's a non-specific marker. But mind you, okay, so we are going to get there. So let's just continue like that. So there's another marker that we call ferritin. That's another acute phase reactor. Now, what does this one do? How does it help? It binds because ferritin is a form that will store iron. So it binds and sequesters iron in the macrophages of the bone and the liver. So the macrophage of the bone, particularly the osteoclasts, the macrophage of the liver, the Kupffer cells, they take in a lot of ferritin so that they can store iron. Why are they storing this iron? Iron is one of those agents that our microbes use to thrive. So they use the microbes to produce some enzymes that are involved in DNA synthesis and replication. So if we deprive them of that iron by sequestering our ferritin within the macrophages, there's no iron that's available for those macros to use. So they will die. They will die. That's one of the benefits of the acute phase reactants, particularly ferritin. Ferritin is an iron store. It is being sequestered within the macrophages so that it remains unavailable for the microbes. What's the next one? Fibrinogen. Fibrinogen is another acute phase reactant that's not regulated. What does it do? We know that it's a coagulation factor. It can stimulate, it can help with formation of the clot. So when it forms the clot forms a scaffold for repair to happen. So before we can even have tissue repair, clot has to have formed first. And aside that, if we have a clot in an area, it kind of confines the white blood cells to that area. The microbes, everything, they are confined to that area so that they don't disseminate. So it helps us to control the inflammatory response in a way. We correlate this with ESR. We are going to explain that later. We correlate fibrinogen to ESR. We are going to explain later. Aptoglobin is another one. Aptoglobin is just a protein that helps to chelate hemoglobin. So if there's any cause for hemoglobinolysis, well, sorry, I said hemolysis, and you have release of hemoglobin into the blood, that
Dr. Bob,
hemoglobin, yeah, Dr. Precious.
sorry to cut you, please. I thought ferritin is that not the storage form of iron in the body? Am I
Yes, you
mistaken?
are right. Storage form, yeah, that's what I said.
So how is it now binding and sequestering iron again?
Yeah, it's like, what they are saying is like it is a form in which iron is stored. Do you get? Ferritin is like a protein complex. That part of that protein complex, iron is there. Do you get it? So
Yes.
where do we store it? We store it in so many places. We can store it in the bone marrow. We can store it in the liver. Do you get it? So
Yeah.
ferritin is present in the liver, is present in the bone marrow, complex to iron. That is it. That is it. So the form that now transfers that iron from places to places is now transferring. So ferritin is the one that will store it in the bone marrow, in the liver, particularly within the macrophages of these structures. The one that will now release it to the tissue that, okay, you go to the lung, you go to the heart, you go to the bone marrow for erythropoiesis, you go to that. The stored form in the bone marrow is not used in hematopoiesis, but it can only be used in hematopoiesis when it is released to transthyretin so that the transthyretin can transfer it to the red blood cell precursor to form red blood cells. So without transferrin, you cannot release iron. That is it. But the storage form is just ferritin. That's how the iron is stored. So the next one is haptoglobin. Haptoglobin is a protein that binds to hemoglobin. So if there's hemolysis from any cause, maybe sickle cell anemia, there's hemolysis, we don't want that hemoglobin to be loitering around, because hemoglobin contains iron, and iron can generate free radical, and free radical can cause oxidative stress that will start causing inflammatory problems. We don't want that to happen. So in acute phase reactant, you have, because sepsis can develop, sepsis can cause hemolysis, hemoglobin will be elevated in there. So the body will respond to that by releasing haptoglobin, and what will the haptoglobin do? Haptoglobin will now start mopping those hemoglobin, forming some complexes that cannot readily release iron, just to protect against oxidative stress by the mechanism we have explained. So the iron cannot be released, it cannot enter the Fenton reaction, it cannot combine with hydrogen peroxide, and it cannot generate the hydroxy free radical. The next one is hepcidin. Hepcidin is also upregulated. What is it doing? Hepcidin is just like the ferritin. So what it's doing is that it will inhibit the formation of ferroportin. So ferroportin is a transporter within the intestinal epithelial cells. It will break down that ferroportin, and that ferroportin will not allow absorption of iron from the intestine into the blood. So that's what hepcidin does. Hepcidin degrades ferroportin, and ferroportin is a transporter that allows uptake of iron from the intestine into the blood. So when there's reduced absorption of iron, there is reduced iron available for the microbes to thrive, so they will die. And in addition to degrading ferroportin, it will bind to the macrophages. Hepcidin will bind to the macrophages, and to prevent iron from being released from the macrophages into the blood. We said the iron is already existing as ferritin in the macrophages. So the hepcidin will now further bind to those macrophages to prevent them from releasing the iron. That is the mechanism of anemia of chronic disease. So if somebody is having chronic disease, and there's in chronic disease, there's elaboration of this hepcidin because it is an acute phase reactant. So hepcidin is elaborated in chronic disease because that is a chronic inflammatory disease. So because of that, hepcidin will degrade the ferroportin in the intestine, and they cannot absorb iron. It will also inhibit the macrophages from releasing iron. So that means that there's little iron available for the bone marrow to form red blood cell. So that means there will be anemia of chronic disease because of that hepcidin. The reason why procalcitonin and serum amyloid A is not actually clear, but both of them can be elevated in inflammation. Procalcitonin is particularly elevated in bacterial infection. It is normal in viral, so you should pay attention to that. Procalcitonin is increased in bacterial and normal in viral. Serum amyloid protein 2 is elevated, and the clinical relevance of that is that it can be a cause of amyloid, amyloidosis in somebody with chronic inflammatory disease. It can cause secondary amyloidosis due to its prolonged elevation. So let's go to the ones that are downregulated. So the ones that are downregulated, there are three: albumin, transferrin, and transthyretin. Albumin, transferrin, and transthyretin. So ATT, ATT, ATT. I've talked about transthyretin today. So I've slightly mentioned transferrin, albumin. Albumin is one of the major protein in the plasma that maintains the colloidal osmotic pressure. That is the pressure of the proteins within the vascular compartment is actually predominantly exerted by albumin. So what we do during inflammatory response is to downregulate that albumin. Why? Because it's a protein. So that we can conserve the amino acid that we use to synthesize that albumin to produce all these other acute phase reactant that we need to upregulate. So it makes sense. Albumin doesn't do much function for us. So why not just reduce the synthesis, downregulate it, and use that amino acid to produce the other ones like fibrinogen, like haptoglobin, that are more beneficial. The next one that is downregulated is what? The transthyretin. So that is why chronic inflammatory disease cannot cause transthyretin amyloidosis. It can only happen if there's a familial form from the mutation, or there's aging in which the transthyretin that is being produced normally begins to misfold with age. So it's also known as prealbumin. We downregulate it so that it can conserve amino acid to form the positive one. Then the last one is transferrin. Now, this transferrin is being degraded by the macrophages. So the macrophages will take in the transferrin and they will degrade it so that there's little transferrin available to be transferring iron to the tissues, to the cell. Because if transferrin is available, it will be transferring iron to the cell, and iron will be available for the macrophage to thrive on. So we don't want that to happen. So the macrophages will respond to that transferrin, they will mop it up, they will break it down so that you have no protein to allow transfer of iron to the cells. So that is that about the acute reactant. So let's talk about the electro the
Dr. Brother.
yes, Dr.
So in a nutshell, they are not even they're not direct products of inflammation or infection. They are just ways the body tries to get rid of
Exactly,
the
exactly.
infection.
You get they are negative acute reactant. That is acute protein that are downregulated, that are not produced, you know, in order to facilitate the production of the positive ones. Exactly. So that is what it means. So ESR. So ESR is just talking about. I know this is a test that we commonly order, in clinical practice. We are very familiar with it. So the mechanism of ESR is just to look at the rate by which the red blood cells can sediment in a vertical tube. So we put this red blood cell in a vertical tube, it contains the blood, then it is being centrifuged, then we look at the way it sediments. So if it sediments fast, the erythrocyte sedimentation rate is high. Now, the only thing that can make it sediment fast is when the red blood cells agglutinate together and their density increases. So with the aid of gravity, they are going to sediment because they have clumped together, their weight is now increased, the gravity can now act on them and bring them down faster compared to the ones that are not clumped, the ones that are not aggregated. Now, we must know that red blood cells on their outer membrane, they have this salicylic acid glycoprotein that carries negative charge. So because of that, red blood cells tends to repel each other. They repel each other because of those negative charge. Yes. But if there's inflammation, there's increase in production of some of those positive acute phase reactants like fibrinogen. Fibrinogen will be able to bind to those negative charge and neutralize them. So in the absence of those charges, the red blood cell will be able to come together, assisted by even this fibrinogen. They aggregate and they are denser and they will fall at a high rate. So the quick way to just spam it is that's the explanation. But the quick way to just decipher is just okay. Whenever there is anything that is elaborating fibrinogen, the cells are going to agglutinate and the ESR is going to fall faster and the ESR will be elevated. The erythrocyte sedimentation will be higher, with inflammation that is causing expression of the fibrinogen. So anything that is down regulating fibrinogen or that is not an inflammatory response is going to allow the negative charges to persist and the cells cannot attract each other and they don't become agglutinated and their density is reduced and they will fall at a lower rate and ESR will drop. Now let us look at those causes one by one. Okay, before we move, so they said it's been co-tested with C-reactive protein. Yeah, so we combine both of them together. But C-reactive protein is a more specific marker for inflammation compared to ESR. Yeah, because it will take time for ESR to actually change in response to the inflammation compared to CRP. CRP rises and fall almost rapidly with inflammation. So we try to believe our CRP more than ESR, but both of them they're actually non-specific. They don't tell us the exact one. It's just that one is relatively more specific than the other. It's not that that one that is even specific is excellently specific. No. So that is it. So when we are saying specific marker, so we are saying that if we see reduced ESR and we are seeing increased CRP, we will still take that for an inflammatory response. Yes, because we believe CRP more than ESR. If we see increased ESR and reduced CRP, we'll be skeptical about making diagnosis of inflammatory response because CRP is a more specific marker of inflammation than ESR. So that's the point I want us to know there. CRP is the most important of all those positive phase reactants for inflammation. So what are those things that affect ESR? What are those things that increase ESR? So we have to understand one principle first. polycythemia and anemia. Once we are able to figure out that, we'll be able to understand the remaining. So polycythemia and anemia. Polycythemia is when we have the increase in the red blood cell mass. So if there's increase in the red blood cell mass, that means that the other constituent of plasma will be kind of diluted relatively. So, and part of those things that are suspended in plasma include our fibrinogen. So the red blood cell will dilute those fibrinogen, and we have the negative charges persisting, because we even have more negative charges number relative to the fibrinogen. So because if the red blood cell is too much, we have little fibrinogen to neutralize all of them. So the other ones will start separating, and they will not aggregate together, and they will fall at a slower rate. So the SR will reduce. So that is that. Is how you permit that, okay, the red blood cell will neutralize the fibrinogen, and you have little fibrinogen to cause increased ESR. That is that. So little fibrinogen will cause reduced ESR. In anemia, just picture it that is the reverse of polycythemia. In anemia, we have little red blood cell compared to the fibrinogen. So the fibrinogen outweighs the red blood cell. So the fibrinogen will be able to neutralize all the charges of the red blood cell. They are going to agglutinate, and the ESR will be elevated. That is it. For the other causes of increased ESR, infection. So infection will drive inflammatory response. Fibrinogen will be expressed. There is going to be increase in ESR. Inflammatory diseases, particularly giant cell arthritis. Guys, I want us to pound this today. Giant cell arthritis and polymyalgia rheumatica works together. They go hand in hand. If you make diagnosis of a patient with polymyalgia rheumatica, a 50-year-old woman having joint pain, polymyalgia, multiple joint pain, particularly the hip, the shoulder, and the person is having rheumatica. Rheumatica means stiffness. So you are seeing history of joint pain, joint stiffness, and you do the ESR, it is elevated. We should have polymyalgia rheumatica in mind. Polymyalgia rheumatica have been associated with giant cell arthritis. They go hand in hand. So you want to make sure that this person is not having headache, the person is not having ocular problems, the person is not having jaw claudication, because those are the typical features of someone that has the giant cell arthritis, because they go together. So once you just because you can see it in question, it has been asked before. Once you see polymyalgia, they will ask you what complications are shared with this disease, or what, sorry, not complication, what can be associated with this condition. Giant cell arthritis, temporal arthritis. So giant cell arthritis and polymyalgia rheumatica, they go together, and they are inflammatory diseases that are associated with elevated ESR. So once we know this, we are okay. We are okay. So with respect to inflammatory disease, we should pay attention more to these two guys. ESR is more elevated in them than the other diseases. Then cancer, both multiple myeloma and metastasis, anyone, all cancer generally, they drive the inflammatory process. So ESR is going to be, because cancers elaborate cytokines, they elaborate all manner of things. So that's why they can cause fever, because they can cause fever, they can cause cachexia, they can cause so many things, because of the inflammatory drive that they typically cause. So because of the inflammatory response, there's fibrinogen in cancer, there is increased ESR. In someone that has nephrotic syndrome or end-stage renal disease, so for nephrotic syndrome now, there's a drop in the in proteins, particularly albumin. Yeah, there's a drop in albumin, but remember that fibrinogen is bigger than albumin. So fibrinogen doesn't escape in nephrotic syndrome. It actually accumulates. And again, part of the protein that escape in nephrotic syndrome includes antitrophin 3. And remember that antitrophin 3 is what? Is an anticoagulatory protein. So if we are losing antitrophin 3, it means that we are losing an anticoagulatory protein. That means that we are going to have unopposed coagulation. And part of those coagulation factors that will be activated is fibrinogen. So fibrinogen is going to be much in the circulation to bind to those red blood cells and increase ESR. That's a way we can figure that out. Another way for the end-stage renal disease, like, we can just link it to anemia. End-stage renal disease can cause anemia. So it can cause anemia from iron deficiency, from chronic inflammatory disease, and all those things. So remember that end-stage renal disease particularly is a chronic inflammatory disease. So chronic kidney disease or end-stage renal disease, chronic inflammatory response, there's activity of the hepcidin, iron deficiency, happened, or anemia of chronic disease. Which one whichever one we want to stay, there's anemia. And we've said it that anemia will increase ESR. Another way to look at it is by hemodilution. So we know that in CKD or in pregnancy, there's or even in nephrotic syndrome, there's edema everywhere, diluting the red blood cell. So when there's hemodilution, we are kind of creating a relative anemic environment. So the fibrinogen can easily, overcome all the red blood cell, make them agglutinate and increase the ESR. So the hemodilution is going to cause situation of anemia that can increase the ESR. Then let's go to the ones that decrease the ESR. Number one, anything that alters the shape of the red blood cell can cause reduced ESR, like microcytosis when the cells are very small, sickle cell anemia when they have abnormal shape. Because in these two conditions, there's a reduction in the surface area of the red blood cell. So there's a reduced surface area for fibrinogen to bind to. So if fibrinogen cannot bind to them, it will cause, reduction in the ESR. We've explained polycythemia. The red blood cells that are more will dilute the fibrinogen, and you have little fibrinogen to cause the aggregation of the red blood cell, and the ESR will fall. Hypofibrinogenemia is straightforward. Hypofibrinogenemia, there's no fibrinogen, so ESR will drop. The only one that we cannot explain is heart failure, because typically heart failure should normally cause ESR, but the pathophysiology for heart failure causing reduction in ESR is not actually known. So we should just have that in the back of our mind that heart failure is the only one that causes reduction in ESR by unknown mechanism. So some people are just talking about drugs and all those things, but the pathophysiology is not actually known for heart failure. Yeah, so what is acute inflammation? We've talked about this initially. We said it's a transient, it's a short-lived, early response, quick response to injury or infection. So there's an injury, maybe from trauma, that's eventually causing necrosis, we can trigger inflammation. Or there's an infection releasing this pathogen and shared molecular pattern that can be recognized by the macrophages, and they can trigger inflammation from there. But what I just want us to know is that in the early phase of acute inflammation, it is the neutrophils that are characteristic. You see them, they are the ones that are looking blue in this slide. These are neutrophilic infiltrate. Once you see any blue stuff like this, this is likely to be neutrophilic infiltrate. So they are shared with all the cardinal symptoms of inflammation that we've talked about. So there's going to be vasodilation. So when the infection comes in, the macrophages, the mast cells, the resident dendritic cells, they are going to release histamine, they are going to release bradykinin, nitric oxide, prostaglandin, that will cause vasodilation. The purpose of the vasodilation is to bring in the white blood cells. When the white blood cell comes in, particularly the macrophages will recognize that microbe. It will use its own toll-like receptor to identify the microbe and activate the immune response by releasing interleukin-1 and TNF-alpha. You see, interleukin-1 is one mediator that actually initiates release of so many interleukins. Both interleukin-8, 12, everything can be stimulated by interleukin-1. Interleukin-1 is even sufficient to drive inflammatory response. So, it will now start releasing interleukins, interleukin-1, TNF, interleukin-8, and the other one. So, the interleukin-1 and the TNF are going to activate the nearby endothelial cells. They are going to start activating them. Interleukin-8 is going to start recruiting our neutrophils to that area. So, neutrophils get to that area and they bind to the activated endothelial cells. So, we are going to talk about the binding, the interplay between the integrin, the selectin, the ICAM, the glycan. We are going to talk about it later. So, those interaction of those selectin and the Salix X, the glycan and those things between the neutrophil and the endothelium is going to make the endothelium find its way into the into the site of inflammation. So, and also we've talked about the fact that interleukin-1 and the TNF-alpha, in addition to causing activation of the endothelium, they can also cause contraction of the endothelial cells, so that fluid that is rich in plasma, the macrophages can also move to that area into the tissue and cause edema in the process. So we must always know that it is rapid in onset and it's very short. Once the neutrophils enters, they quickly destroy those macros because they are phagocytic too. They phagocytose those debris and they leave because they are short-lived. Neutrophils die within like 3 to 5 days. They die. They die by apoptosis. Once they are done with their action, they die by apoptosis, and everything ends. There's no destruction. You destroy the offending agent, the neutrophils die. There's resolution. There's no problem. There's no problem. So it is typically it typically involves the innate immune system. It's not like chronic inflammation that involves the adaptive immunity. When you start talking about the B cells, the T cells, and yeah, that's that. So let's look at the stimuli that can trigger acute inflammation. Infection, trauma, necrosis, and foreign body are potential stimuli that can drive acute inflammation. So we've talked about this infection, trauma, will cause damage to the endothelial cells. It can even cause cell death, and inflammatory drive will happen from there. Necrosis from any cause. Foreign body, for example, someone that is inhaling, let's say like person is inhaling like pollen dust now. So in response to that pollen dust, there's going to be an acute inflammatory response that will lead to elaboration of our eosinophils. So all the mast cells, the basophils, they are going to release eosinophilic chemotactic agent. They are going to draw out the eosinophil to that area to respond to that. So that's an acute inflammatory response to foreign body, like pollen, like dust mites, like whatever thing that can trigger inflammation. So infection, trauma, necrosis, and foreign body. So that is why we start talking about the damp and the palm. So the palm are the pathogens that share molecular pattern. For example, in infection, the pathogen share molecular pattern. While the damps will be the uh the damaged tissue, molecular pattern, maybe from necrosis, from trauma, those proteins that will be released from the cell, mitochondrial protein, free living DNA, and all those things, they are damaged associated molecular pattern because you should not have your DNA free living in the blood. Mitochondrial protein should not be released in the blood, but all those things can be released when there's necrosis or when there's trauma to a particular cell. So those ones will be recognized, will serve as damage associated molecular pattern that can be recognized by the toll-like receptor of the dendritic cells as well as the macrophages, and they will initiate the inflammatory cascade by releasing interleukins that will activate the endometrium, and also, I said endometrium, endothelium, and also recruit the neutrophils. Or, depending on the response, recruit eosinophils. They can recruit anything. It's just depending on what is causing that inflammatory response. So what are the typical mediators? The toll-like receptors. I've mentioned the toll-like receptor where it works. It's present in the dendritic cells, it's present in macrophages. Those are the ones that express the toll-like receptor to recognize the PAMPs, which is the pathogen and share molecular pattern on the microbes and the DAMPs from the damaged tissue. The mast cells and the basophils, the dendritic cells, they are going to release prostaglandins. They are arachidonic acid metabolites. And we've said it that the activity of prostaglandin is what? Is to cause vasodilation, particularly prostaglandin high 2, which is increased, which is produced by the COX-2 activity. They cause vasodilation so that you can have the white blood cell coming around. We are going to have the neutrophils coming around. If it's a case of type 1 hypersensitivity or allergy, the eosinophils will be there. They'll be recruited by the mast cells by releasing the eosinophil chemoattractant protein. So antibodies that are preformed too can be lying around, and if the macrophages, if the cell has been exposed to that what's it called, the antigen before, the antibody can easily combine to them and neutralize them. Then mast cells too, of course, that is even what is initiating the stuff in the first place by reducing histamine, bradykinin, prostaglandin that cause vasodilation. The basophils are not typically present in the tissues, but they can be in the blood, and they are actually elevated in allergic reactions. So if somebody is exposed to a foreign body like pollen, dust mite that wants to trigger the allergic response, the basophil will be there to help with that. So they can degranulate by releasing histamine, tryptase, and all those things that cause vasodilation and recruit more white blood cells to take care of the foreign body. The complement protein are also activated. So we can have, complement protein activation for microbes. So if the microbes come around, they can activate the complement protein from the mannose binding lecithin pathway or from the alternate pathway, and you have elevation of those microbes and elevation of those complement protein rather. And what will they do? They have so many functions. So if it's a situation of anaphylaxis now from maybe a foreign body, they can, initiate production of the C3A, C4A, C5A, that can drive the anaphylactic response. If it's a situation of bacterial infection, they can increase production of C3b that can stimulate opsonization of that bacterial infection. So the complement protein are very, very active in inflammatory response because they are part of the innate immunity. Then lastly, Edgeman factor, factor 12, very important too. Edgeman factor is very important, particularly in setting of trauma. So if there's trauma, there's damage to the endothelial, there's exposure of the endothelial collagen, which will activate the factor 12 to activate the intrinsic pathway of coagulation. So they want to ensure coagulation to initiate the process of tissue repair. And this Edgeman factor also activates kallikrein. So kallikrein is an enzyme that converts prokininogen or kininogen to bradykinin. And we said bradykinin is one of those inflammatory response. It's one of those inflammatory mediators rather that cause vasodilation, that brings about tumor, and that also stimulate the sensory nerve for pain. Now, in addition to activation of the macrophage from this toll-like receptor and all those things, we also call something inflammasome. So inflammasome can also be a pathway for activation of the inflammatory response, the acute inflammatory response. The inflammasome are cytoplasmic protein complex that are typically contained within epithelial cells. So if there's any breach of epithelial cell, you can activate this cytoplasmic protein complex. And what would they do? So if it's due to necrosis of those cells, or if it's due to inoculation of microbial product or crystals, foreign body, like uric acid, what they will do is that this cytoplasmic protein complex will be activated and it will bind to all these DAMPs. It will bind to the DAMPs, which is a damaged shared molecular pattern. Some of them will also bind to the 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 PAMPs, which is the pathogen shared molecular pattern. So an example of the pathogen shared molecular pattern are the microbial products. So the microbial products are PAMPs. They can easily fuse with this cytoplasmic protein complex. Then the DAMPs, which are damaged shared molecular pattern, can also fuse with the cytoplasmic protein complex. So example of those DAMPs are from necrotic tissues and all those things. So at the end of the day, when there's a fusion with the cytoplasmic protein complex forming the inflammasome, they will release interleukin 1. So interleukin 1 is a major interleukin that's released, and interleukin 1 can facilitate release of other interleukin that will now drive the inflammatory response. So don't forget, inflammasome is very important in activation of the acute inflammatory pathway. So these are the steps we are just talking about all over and over again. The component, the vascular and the cellular. So the vascular is starting with the vasodilation. Like we've said, there's an increase in the blood flow from the activity of the histamine, the prostaglandin, the bradykinin, the nitric oxide. So when the blood flow comes around, there is release of the histamine as well, the bradykinin, the leukotriene that will cause increased endothelial permeability so that the blood that is there can now extravasate into the tissue and cause edema. Now, extravasation of that blood, that fluid into the tissue is going to increase the viscosity of the blood and slow the blood down. So as it slows the blood down, some of those neutrophils that have come around from the increased blood flow will now adhere to the endothelium so that they can also extravasate into the tissues. So that is the reason why stasis can actually help with the transport of the neutrophils from the blood into the tissues. That is that. So that's what happened in the vascular response. They just increased vasodilation and there's increased endothelial permeability. That's the two things. Then the next thing is the cells will now take over. So when the cells now adhere to those endothelial cells, they can move. Now, how it adheres is that normally, during this inflammation, when there's this blood flow increase from the vasodilation, there's a change in the distribution of the flow of the cells. The red blood cell will assume a central distribution. They assume a central distribution, while the white blood cells will be pushed to the periphery. So there's margination of the white blood cell. So they are pushed to the periphery so that they can adhere to the endothelial cells at the postcapillary venous. Remember we said that vasodilation occurs at the arterioles, while extravasation occurs at the postcapillary venous. So that's where we have the what's it called? The leukocyte adhering, then moving to the tissues so that they can now get to the tissues and go and attack the microbe that is causing the injury. So we have four stages of leukocyte extravasation. The first one is when it's marginalized to or it marginates to the endothelium. Then when it marginates to the endothelium, that stasis that is happening due to the extravasation of the fluid causing viscosity will now make the uh the blood flow to reduce so that the neutrophils will have enough time to adhere to those endothelial cells. When it adheres to them, we don't call it adhesion at that point. They will bind to them and they will start rolling. That one is actually due to the fact that the blood flow has slowed down. So by the time they are rolling, they cannot have enough time to now firmly adhere to those endothelial cells. That is adhesion. Then when they adhere firmly to those endothelial cells, they will now move across the endothelial cell into the tissue. That is transmigration. We are moving across something. Transmigration. When it now gets to that tissue, it now moves within the interstitial space of the tissue, that is within the tissue, to go to the site where these bacteria are. Definitely, that's now what we call migration. Migration. And the mechanism that is attracting migration is actually release of chemoattractant. Chemoattractant will be released by those bacterial cells. We know the chemoattractant for neutrophils: interleukin 8, 5-HT, C5a, N for mimet. We have a lot of them. We are going to see them. So I'm just trying to just brief us about these steps. The first thing is the neutrophils will be marginized. They will go to the margin of the endothelial cell to, stay there. Then the next thing is they are going to start rolling of those endometrial cells due to the sluggish flow of the blood. Then as they are rolling, they will now start adhering firmly, which is adhesion. When they adhere firmly, they will now cross the endothelial cell. That is the transmigration. When you are moving across something, you are migrating across. Transmigration to get into the tissues. When they get into the tissue, they will now move through the tissues. That is migration in response to the chemoattractant that is stimulated or released by the microbes. So that's the stages of leukocyte extravasation. They are going to ask you one of these in your exam. You can see this. They ask it, yeah, you see it. So we must know it very well. So what are the outcomes? Um, so they can be resolution and healing, which is a normal one that we've talked about. So once what are the outcomes of this acute inflammation? So once the neutrophils get to that area, they take care of the microbes. The body starts releasing interleukin 10 and beta, which are TGF beta, which are anti-inflammatory mediators that can subside that inflammatory response so that the the inflammatory response will not be excessive. So there's eventual resolution of the inflammatory drive and everything goes back to normal. In some situations, it can be persistent. For example, someone that has sepsis, you are there's elaboration of so many interleukin like interleukin 8. Neutrophils are always coming around, attacking, you know, and the inflammation will not subside until it eventually cause organ failure. In some situations, acute inflammation can progress to abscess. So this abscess formation typically depends on the nature of the inflammatory stimulus. It depends on the typical organism that is driving the inflammatory response and the typical tissue or the site of the inflammation. For example, there are some infections that are notorious for causing abscess, like Staph aureus. They are notorious because Staph aureus has some virulent organism mechanism, like it can form coagulum. So it forms some clot around itself, walling off itself around that inflammatory site so that they cannot take care of it. At the end of the day, it's going to lead to formation of abscess because it's going to be walled off. Abscess are very common in some tissues like the lungs, because the nearby cells can easily respond to that inflammatory drive by proliferating fibroblasts, proliferating capillaries so that they can wall those or form a cavity around those inflammatory sites so that it doesn't get to them. That will lead to abscess. So that's why I'm saying it depends on the stimulus. If it's due to some certain bacteria like Staph aureus, they can form abscess. So depending on the location too, it's very common in the lung, in the skin. Those areas, the neighboring LD tissue tries to wall off the infection so that it doesn't get to them. That will lead to abscess. Chronic inflammation, that is the stimulus is very persistent. That stimulus is not something that you can eradicate, like someone that has tuberculosis. It will progress to chronic inflammation. So they want to recruit the mono nuclear cells, like the plasma cells, like the T cells, to help us take care of them. So the macrophages will now be forced to, activate the CD4 cells, which will lead to chronic inflammatory response. And one of the complications of chronic inflammatory response is one scarring. It will lead to fibrosis at the end of the day. So these are the spectrum of possibilities from chronic inflammation, from acute inflammation. What we typically expect is resolution and clearance. So, and it is due to the fact that the white blood cells start releasing interleukin 10 and TGF beta, which are anti-inflammatory mediators that will subside the inflammatory response. In some situation, if it gets to the blood and it becomes massive, we have this um, self-perpetuating release of interleukins, like in sepsis, which will make the inflammatory response persistent. In some situation, they can form abscess. So inflammatory response is kind of encased in a cavity due to an organism or due to the region where it is happening. It can progress to chronic inflammation if the stimulus is not being eradicated, which can lead to scarring at the end of the day. So the initial cells that are predominant in acute inflammation is neutrophils. We've said that. But neutrophils don't live long. Within 2 to 3 days, they are dead. So they'll be replaced by the macrophages. So macrophages are phagocytic. They can take care of the cellular debris, they can mop up those microorganisms, and they can initiate tissue repair. That is that. So what will now be, would be dependent on what this macrophage has done. If the macrophages are able to contain infection, it will lead to resolution. If the macrophages are not able to contain it and they start releasing some cytokines that activate T cells, it will lead to chronic inflammation. And one of the complications of chronic inflammation is scar formation. So by evening we'll start talking about these other ones. Very soon we will end them. So do you have any questions so far? Any questions so far? Hello, my people, are we
No
there?
question. You are
No
here.
question. That's all.
So it is clear to us.
Okay.
Everything is clear.
Yeah.
Okay.
Bye.
All right. So we'll meet again in the evening by God's grace. Bye bye, everybody.
Bye
Bye.
bye.
Bye. Thank you.